Welcome to a Cisco meeting. You are entering the meeting now. This meeting is being recorded. You are the only participant.
Test, test. Test, test.
All right. Good morning, everybody. We just found out Grace was out, so I'm going to present a 2-minute cow. I just put it together in 30 seconds, so forgive the lack of any kind of graphics or really research. It was just a case that I found interesting and had a conclusion to it, and that had me very, it was thought-provoking. So I had a patient in her 70s. I saw her in same day with Dr. Peterson. She had been seen in our clinic before by another provider for these welts that she was getting all over her body for the last several weeks. The provider who saw her initially had done a biopsy, and it showed a hypersensitivity reaction, and had asked her to please make sure she wasn't getting bitten by bugs. So she got an exterminator to come to her house, did this series of extermination things, to get rid of all the bed bugs. She did everything she was supposed to do. And so we sort of said, okay, maybe this isn't bed bugs. She did all that. She still is getting new lesions. And this looked, it was like edematous, almost infiltrated, and very itchy. So we did a biopsy, and she was describing like pain almost in these burning pains. So we did a biopsy, and the biopsy was interesting. It came back with periadnexal, perifollicular, and deep lymphocytic infiltrate, consistent with possible connective tissue disease, something like tumid lupus. Could potentially have been an odd drug reaction. There weren't any eosinophils though. So we were like, wow, that doesn't really fit with what we saw. Tumid lupus, these lesions, maybe you could buy them for tumid lupus, but they were going away within several days. So we embarked on a big workup. We had done a DIF, which was negative. We did SPEP, we did ANA, we did a whole lot of labs, none of which really came back helpful. And so I saw her again in clinic. These were getting so symptomatic, and she was getting so many of them that we had started cyclosporin, which she is tolerating well and was actually really improving her symptoms and the amount of these new lesions she was getting. But I really, frankly, didn't have a great diagnosis. And I saw her back in clinic, and we were thinking about biopsying her again, but she was doing okay. And then finally, on like the 4th follow-up, she came back and she's like, I know what I have. It's bed bugs. She had seen bed bugs in her house. So the whole point is that if you think it might be bed bugs, even if they've gone through the exterminator, even if the biopsy makes no sense, really consider bed bugs. They're pesky and they are very hard to get rid of. I had done a lot of workup on this woman. We didn't know what she had. The biopsy made no sense at all. She was getting them sporadically sort of everywhere, but it wasn't like a particular distribution, definitely head and neck. And they were like painful, big, indurated welts. And, these are bed bugs. Simex is, okay, so here's the follow-up, is that she left her apartment. She moved to Virginia. She stayed in a hotel for a week in between moving to Virginia to be with her daughter. And because of these, and she didn't get any new spots at all. So that sort of sealed the deal for me. She had pictures of the bed bugs on her skin, but they stopped as soon as she was not in her apartment. She didn't get any more new spots. And so I had sort of written off bed bugs or arthropod because the biopsy didn't make sense, and because she had an exterminator come to her house and she had washed all the sheets and washed all her clothes and had done all of that stuff. But still, it might be bed bugs. So the only thing I looked up at all is the name of the genus, which is Cimex, C-I-M-E-X. So that's bed bugs. And that's a very brief cow. Thank you.
Okay, I guess we'll just move on to your talk, Dr. Grossman.
No, not the video.
Okay.
Sorry, what? Oh, yeah, that's fine. Okay, good morning. I'm going to talk today about the pigmented lesion assay, PLA, for non-invasive assessment of clinically atypical pigmented lesions. How many people have heard of this? 2, 3? How many people have tried it on a patient? Just me. Okay. So we'll show you some interesting things today. I really think this is the most significant advance in early melanoma detection in the last 10 years. And so I'm kind of excited about it. I'm still not quite sure how I'm going to use it. I'm trying to still figure that out. Couple of disclosures. This is a commercial product, but I have no financial interest in the company or product, and I'm not a paid consultant or speaker for them. So this is a GEP, gene expression profiling test, in which two genes are examined, expression of two genes from stratum corneum that's obtained by non-invasive tape stripping. And from that material, RNA is extracted, and these genes are amplified by PCR, and the expression is quantitated. And you just register at the company's website, and they send you as many kits as you want for free. And you basically send them back in with a prepaid mailer and log into the online portal a day or two later and get the results. It's that simple. They bill the insurance, patient's insurance company. If the insurance company declines to cover the test, the patient is charged $50, and they guarantee the patient will not be charged more than that. And if there's any technical problem with running the test or something that you don't do correctly, they don't charge at all. And if you do more than 3 lesions on the same day, they don't charge for more than 3. And so we had an initial experience with this company about 15 years ago. I was involved in a trial which they were just trying to develop this technology. The test was called MELDetect. And we enrolled patients in this trial in which lesions that were selected for biopsy, melanocytic lesions, we applied their adhesive tape and sent that in. But there was a problem with a couple of the specimens, and I don't know if, Scott, you remember this, right? Annalie took this photo for me about 15 years ago. I get this call from Scott. What's going on with some of these biopsies you're doing? Totally disrupted architecture. The adhesive patch, when you pulled it off, was just totally, creating so much shear force. It was just fracturing the epidermis and dermis, and so the lesions were uninterpretable. So that was a major problem, so we withdrew from the trial. Since then, they've modified the adhesive, and it doesn't do that anymore. So what are these two? Thank you. What are these two genes? The first one is a link gene, link 518, and link stands for long intergenic non-protein coding RNA. So it's a gene that doesn't encode for a protein, but it regulates other genes and microRNAs. And it's been shown to be important in cell growth and metastasis. And it's highly expressed in melanoma. Do we have a pointer? Oh. And so comparing expression in melanoma lesions compared to adjacent normal tissue, there's a significant difference in expression. And melanomas that express this particular link, the patients do worse. The other gene is called PRAME, which stands for Preferentially Expressed Antigen Melanoma. This is a tumor-associated protein not expressed in normal tissues, and it's a member of this family of cancer testis antigens that are thought to be important targets for immunotherapy. It's generally not expressed in normal nevi. It is expressed focally in a fraction of dysplastic nevi, Spitz nevi, recurrent nevi. But it's broadly expressed in the majority of melanomas. So those are the two genes. And when they developed this test, they started looking at panels of genes and started out with a panel of about 17, and they found they could get the same diagnostic predictive value, narrowing it down to just these two genes, the link and the PRAME. And these were the results from the initial study in which lesions were tape stripped and then biopsied, and they correlated the expression results with the histologic findings. And they found that if both genes were expressed, 90% of those lesions proved to be melanoma. If only the link gene was expressed, about 10% were melanoma. If only PRAME, 50%. And if neither was expressed, less than 1% of those were melanoma. A follow-up study yielded similar performance. And then more recent study that was performed looked at a number of lesions, and so here you have 380 lesions, 330 were double gene negative, so biopsy was deferred. 51 were positive for one or both genes. Those were all biopsied, and 37% proved to be melanoma. So positive predictive value about a third. And then this is the most recent paper that came out documenting over 2,000 lesions, 700 that had greater than 1 year follow-up, and that negative predictive value of 99% seems to be holding up. So they're not observing any melanomas developing in, at least clinically, in these lesions that are testing double negative and not biopsied. So I was pretty skeptical about this. I was interested, but I was skeptical that one could actually capture genetic material that was relevant to an underlying nevus or melanoma just by sampling the stratum corneum and only looking at 2 genes. I really did not think that this was going to work. All of us have resistance to change. I've been doing this for a long time, and to try to introduce something new in my clinic, it was kind of hard for me. And then, obviously, if the test is allowing you to avoid biopsies, there's a financial disincentive to use the test. But it turned out that these kind of concerns really were outweighed for me by a number of factors. One, I think that if there's new technology, we do have an obligation to try to use it and just see if it potentially can help our patients. And particularly in my clinic, I'm seeing lots of high-risk patients, lots of nevi, and we're really trying to avoid unnecessary biopsies. And this might be a way to do that. And maybe it could facilitate the way we're doing total body photography in terms of early melanoma detection. And maybe there are some difficult clinical situations, which I'm going to show you, where we often don't know what to do, even when we've got total body photography. And this might be useful to guide biopsy decisions. So this is one of the first patients that was noted to have a new lesion. She didn't think it had significantly changed, but she was worried about it. Clearly, it's new there compared to the photograph. So I thought this might be a good one. We did the assay. It was double gene negative, low risk. So we said, let's just observe that. Another case, new lesion observed at a follow-up visit. And here's an example. Often, just because it's a new lesion doesn't mean it's concerning. If you can have an explanation for some of the features of the lesion that might initially appear clinically atypical. It was actually a combined lesion. There was a new nevus next to this other lesion, and the irregular border could be explained by perifollicular notching, and so I wasn't really worried about that. And that also tested double gene negative, and so I reassured the patient that was probably okay, and we decided to continue to observe that. So for me, initially, the real utility of this test is allowing me to avoid doing a biopsy. If I think the lesion's benign, you can never be 100% sure till you biopsy it, but I thought this would be a way to avoid the biopsy and get some reassurance that my clinical impression was correct. If you've already decided that you're going to biopsy a lesion, there's no reason to do this test. So this test is designed to guide the decision to biopsy or not. This was a new patient I saw. He had no melanoma risk factors. I noticed this clinically atypical lesion on his abdomen. It was, I didn't think it was that concerning. He felt it wasn't changing. Usually I treat a solitary clinically atypical nevus as an ugly duckling on a patient and just take it off. But he really didn't want a scar in that area. On dermoscopy, it really didn't look that concerning to me. I wasn't going to mole map him because he really didn't have any other nevi. So did the test, double gene negative, plan to observe. All right, so here's another case. Photos are about 6 years old, and we do see some pretty symmetric enlargement in this lesion in this patient. She's had a number of biopsies before, and some of these patients, and anything you take off, they're gonna have a lot of dysplasia, and then you get into the dilemma of whether you're going to re-excise or not, and we really wanted to avoid that. And so I thought this would also be a good candidate for the test. And so again, similarly, double negative there, and we just continue to monitor. So not all the cases are going to be like this. This is a patient who usually we don't have to rephotograph patients. Nevi in adults are pretty stable. But now as we're now seeing patients that the photos are like 15 years old. We're finding occasionally we do have to redo the photos. This patient I rephotographed 3 times because every 3 or 4 years there are just so many changes and I couldn't keep up with it. And so when I saw him last year, I noted multiple changes, and the last time I had photographed him was 5 years before. And so multiple lesions that are pretty clinically atypical, showing enlargement. And so I thought he would be a good candidate for the test. And he allowed me to, for us to take a little video while we did it on him. So we'll show that now. We need to minimize, how do we minimize this? Great, thanks. So this really doesn't take much longer than doing a biopsy. You first clean the lesion with this alcohol wipe, and then you basically just use a gauze pad to just kind of rough up the lesion. It just kind of disrupts the stratum corneum a little bit. Then you apply a series of 4 adhesive patches, and then you rub the patch against the skin. That's what I'm doing there to sort of engage the adhesive. And then you circle the lesion with the Sharpie they give you, and so they're only going to isolate material from within that area that you circle. And it's important you don't capture any hairs or any other debris or anything within that area. If there is a lot of hair, we do use the electric razor or just clippers. You don't want to scrape the skin, but yeah, you want to do whatever you can to minimize hairs getting on there. If they do see hairs on there, they'll reject the specimen. So I talked to the company about that. And I said, do you do these like as replicates or something, and they said, no, they just pool them all together, and they just kind of gives them extra material or allows them to reject individual ones if something looks wrong. But they didn't really have a good answer for that when I did ask them about that. So they all came back negative, and so continue to monitor. All right, here's another case. And so fairly long interval between the baseline photo, and this lesion had developed some changes. Often you'll see in younger patients, if lesions are growing, it can be fairly common to see little dots around the periphery of the lesion that represent those nests of melanocytic nests as the lesion's expanding. But it was a little bit asymmetrical. There was some change going on in the center of the lesion. this is one maybe you consider biopsying, but again, a lot of these patients might have multiple lesions like that. And so again, that was one that we were able just to avoid the biopsy by doing the gene test. Here's another case, a little more clinically atypical changes there. And so I wasn't too concerned about it, but clearly it's clinically atypical, clearly it's a change. Patient had multiple biopsies before, really did not want to get another biopsy, and so we're able to avoid the biopsy there as well. Here's a new lesion. Usually I would always biopsy new dark lesions in patients that were high risk. But again, use the test there to avoid the biopsy. So this was a case of not a mole mapping patient, but one of my skin cancer patients who had a solitary atypical nevus on the arm. And from when I first saw him, I said, we should just get rid of this. It's your only nevus. And he said, well, I've had it my whole life. It's never changed, so, no. And so each year I kept seeing him and say, let's take this off. And so he didn't want it off. And then I sort of felt there was a little bit of change going on here, maybe a little bit of regression in that part of the lesion. And so I said, well, let's just do the patch adhesive test and avoid the biopsy. And he was okay with that. Came back single gene positive, so moderate risk. And so I said about a 10% chance this is going to be a melanoma. And so he agreed to come back in, and we took it off, and it was. So melanoma in situ arising in a nevus. So this, I think, is another utility of the test, is a way to convince a patient to agree to getting a biopsy. At least it worked in that patient. Here's another case. Patient with multiple lesions, history of melanoma, number of lesions exhibiting some change, some ectopic foci of pigment there. So I thought some of these would be good candidates for the test. First lesion negative, so we agreed to monitor that. Second one, link positive. So that one I thought we needed to biopsy, and we did, but it was just a dysplastic nevus. So not always going to be melanoma. This was a case of a patient who had no prior history but had lots of nevi. And I noticed that this lesion I thought was significantly changed. It was darker. It had grown a little bit. It was a little bit more irregular. But really on dermoscopy, it actually wasn't concerning. But, clinically to me it was. So again, I said, well, let's just do that. Let's do the adhesive test and try to avoid the biopsy. Comes back double positive, so 90% risk of being melanoma. So we've got to bring you back in, got to do the biopsy. And we did, but it wasn't melanoma, just atypical compound nevus and some architectural disorders. So, didn't have to do anything further. So, in that case, it didn't get us out of the biopsy, and maybe the patient was a little bit more, had a little bit more anxiety, concern because of that result until we got the biopsy result. But that's what happened in that case. So we're just going to monitor the site for recurrence, as we always do. This was kind of a humbling case for me. This patient had melanoma before, and when she came in for annual exam, she had noticed a small change, which I may not have even pointed it out to her if she hadn't have brought it up. I mean, this is just so minimal. This one little dot is a change compared to the baseline. Looking at it, I didn't really think it didn't really look suspicious to me for melanoma. I said, let's just watch this and come back in 6 months. She was worried about it, so I said, okay, let's just do the test, and we'll be able to reassure you. Came back double gene positive, and so and this was a case where I should not have done the test because the patient lived in St. George, and so then she had to come, drive back, 3 hours or however long it takes to get the biopsy, and it was invasive melanoma. So that's one that I would have missed. Eventually, obviously, it would have declared itself on the skin, but I would have certainly missed that. I would not have biopsied that, in my regular way of doing things. So the test did identify melanoma there for me. This is a crazy case. This was a patient who was referred to me who'd had numerous melanomas, and so I said, let's just do mole mapping, and lots of atypical lesions. And let's just, I always have patients come back 3 months after the initial photography to really assess whether there's been any interval change. I find that very useful, and I have picked up new melanomas that way. And so he comes back a couple months later, and only one lesion had changed. And so I biopsied that. That was invasive melanoma. And there was another lesion that I really didn't like the looks of, but it hadn't changed. Biopsy that. That was melanoma in situ. And so I said, well, maybe, we should just do some tape stripping, and, we're not going to charge you for more than 3. And so I tape stripped his 10 most clinically atypical lesions. There they are. Which are the melanomas? All of them could be. But, none of them were dramatically changing over a 3-month interval. So we had the first 3 were double gene positive, and we had a link positive, and then 6 were double gene negative. So brought him back in, and we biopsied the first 4 lesions, and they were all melanoma. Interestingly, the smaller, one of the least atypical lesions ended up being the invasive one, and these were all in situ. So we obviously we then brought him in to get the excisions done here, and then decided to monitor the other lesions. And then when he came back in for the excision, he still had a lot of other lesions. So I said, let's go ahead and we're going to tape strip another 10. So those are another 10 lesions there. And so what are those tests? So one was double positive, one was just link positive, and the rest were negative. So we biopsied those first 2, and those were both melanoma, 0.8 and an in situ lesion. But then we didn't biopsy all the ones that were double negative. So in this patient, basically, we're able to identify 6 melanomas and avoid 14 biopsies. We wrote this up, and it's in press now. But this was another utility of the test, the ability to screen multiple suspicious lesions, much less expensive than doing biopsies. And so another utility of the test, but pretty unusual patient. So my experience so far, I have had some technical failures. One patient, they thought too much hair on there. They rejected it, so I brought the patient back and we repeated it. I had 3 cases where you get back QNS, quantity insufficient, so there wasn't enough RNA isolated. So one of them I repeated, and then the other 2 patients did not want to do it again. So I've done 51 tests last year. We had 39 that were double gene negative, and so those were 39 that I didn't biopsy. I don't know if there are any melanomas there, but we're going to continue to monitor those lesions as we would have anyway. We did have 5 that were link positive, and 3 of those were melanoma, 2 were dysplastic nevi. I didn't have any cases where only PRAME was positive. And then we had 7 double positives. Those were all biopsied, and 5 were melanoma, 2 were dysplastic nevi. So these are sort of the take-home points for this. Remember, if you've decided you want to do the biopsy, then there's no indication for doing this test. This test has only been tested on melanocytic lesions. So, if you're trying to figure out if this is a seborrheic keratosis or not, or a basal cell or something like that, it's not appropriate to do the test because the data will be totally uninterpretable. You can't do it on mucous membranes, palms, soles, nails. If the lesion's ulcerated or bleeding, they've never been tested on those conditions. Never been tested on large congenital nevi. Never been tested in kids. I think that would be a great application for this if it could be validated, because you really don't like doing biopsies in kids, and it's almost never going to be melanoma, and that'd be a way to give you some reassurance. But the test would have to be validated in that population, and it hasn't been. They also recommend that you do not test lesions that are less than 5 millimeters in diameter, because you may not recover sufficient RNA. I've gone down to about 3 millimeters, and it still worked, but that's what they tell you. If it's not practical for the patient to return for a biopsy, then you shouldn't be doing this test, right? Because if you get a positive result, if you're seeing this patient, they're getting ready to go off on their mission or leave the country or something, you're never going to see them again. You want to just go ahead and do the biopsy, but potentially. But I did have 1 or 2 patients where I sort of didn't really think about that, and then it was very inconvenient for them to try to get back in to get the biopsy done. And I also don't think you should be doing it if you're not going to be able to monitor the lesion following a negative result. So when you get a negative result, you still don't know for sure that it's not melanoma or that it may not evolve into melanoma, and so you want to still be able to monitor the lesions. And so if for some reason you don't think you're going to be able to do that, then you probably shouldn't be doing that test. So my final thought, it's been interesting. I'm still trying to figure out the best way to incorporate this into my practice, but it's definitely gotten me out of and into some sticky situations. Any questions?
Hello? Oh, yeah. When you bring patients back, do you charge them for another visit, or how does that work?
You mean if they bring in for the biopsy? I just charge for the biopsy, but no, as I always do. I mean, if someone, like, they come in and they're worried about one spot, I'm not doing a physical exam, and I just biopsy the lesion, then we just charge for the biopsy and not a visit charge.
Sounds like you haven't had the opportunity to biopsy anything that has been tape strip negative yet that has clinically changed in the time that you've been
Correct.
Monitoring. If you were to see a significant clinical change that warranted biopsy a couple of years from now in any of these that have been tested negative, would you assume that it was because it was a new melanoma arising in a previously benign lesion? Would that be an indication to tape strip again prior to biopsying to see if there was melanoma arising, if the genetic signature had changed? Just wondering what your
Yeah, it's a good question. I haven't had that scenario yet. I think I would just do the biopsy, because all you know is that what the gene expression is at that one point in time when you did the test, right? That's all you know. And so we don't have any data about, prediction of evolution into melanoma. One of my colleagues, when they get when they get a double positive and they do a biopsy and it comes back negative, they go back and re-excise the lesion, which I haven't been doing that. But I don't think we really know. The company is planning a study, and I'm trying to decide if I want to be involved in the study, where we're going to do prospective monitoring within long-term follow-up and maybe try to answer some of those questions. But I think if there's a clinically suspicious change, then I would do the biopsy. I guess you could consider, at some later point in time, if that happens, redoing the tape strip. You could consider that. And so I don't know. I have to see what I think about it, but I don't know. Maybe what the patient thinks about it too.
So Nick Benson, who was at Dermtech, and I have been friends for a long time. Back in the day when I was consulting with them, we were interested in inflammatory skin diseases, and the question was, how much RNA do you need? And the answer is 200 micrograms. And then the question is, there are easier ways of getting 200 micrograms off the skin than 4 tape strips? And we learned that, yes, you can do that, but you take histocril or a fast-acting crazy glue, stick it on the skin, let it dry for a few seconds, pull it off, and you'll get about 200 micrograms of RNA.
I think they probably get enough in the first adhesives, but for whatever reason they want you to do 4.
Yeah, so they patented their test, and we patented the histocril approach.
Yeah, so none of those people at DermTech are still there, I think.
Yeah, they're all
and when I
gone.
talked to the people about our experience with the earlier trial, they had no idea that even happened. You know,
Right.
they're just totally.
Yeah, they don't. I've talked to them since then about it and shown them our abstract that we presented at an SID meeting. And interestingly enough, we tape stripped some people with psoriasis and then monitored a number of markers, TNF, IL-4, as I recall, and there were a number of them. But TNF dropped very rapidly with infusion of Enbrel. Or it wasn't an infusion, it was actually just a shot. And so it was within 2 weeks you could tell that there's going to be a response.
So it might be a way to monitor disease progression or recurrence like you would monitor antibodies in a blistering disease or something.
Sure.
They're doing another trial where they're going to look at just other types of inflammatory skin conditions, just a very exploratory thing. And they have another test with similar patches where it's a much broader gene panel, and they're going to sort of try to develop some signatures for other types of, inflammatory skin diseases as well. That's sort of one of the things they're going to think about doing.
So the stratum corneum is like fossils, and so how much RNA is in the fossils? Yeah, the answer is probably more than you think.
Yeah, I just would never have thought this. And I think those of you who are here last month or two and heard Rob Judson, who's new to our department, he's interested in microRNAs. And that, to me, I think makes a lot more sense because microRNA is so much more stable than messenger RNA. But this test, it looks like it works. To some extent. What we really have unknown are those that are double negative that you don't biopsy. But there were 2 prior studies where they did do the biopsies and sort of show that 99% predictive value, negative predictive value, which is going to be a lot better than any dermatologist. None of us operated in the 99 percentile, predictive capacity.
Do you get reimbursed for doing this?
Nope. That was a part of when I had that, the pluses and minuses and the financial disincentives. So you're definitely taking time, and you do not get, the physician does not get any kickback.
And so do you just keep some of these kits on hand, or you order them specifically for each?
Yeah, you keep them on. I try to always have at least 10 available. They send you boxes of 5, and you just order online. Yeah. So, but you do have to register like if you were at HCI and wanted to do it, and I could give you one of the kits, but you have to register because you have to fill out some paperwork, and then they actually you also have to send in like the patient's insurance, and sometimes the insurance company will want your documentation of why in your note you thought it was necessary to do the test, and so it's got to be on your own patient. But it's real easy to sign up if you want to. I'll be glad to talk to anyone if you want to try this. Any other questions? They send the insurance a bill for something like $1,200, and they take whatever the insurance company pays them. I have had a couple of patients that called me in a panic when they got what they thought was a bill for $1,200, but it was simply notifying them that their insurance company was being billed for that amount. So I've never had any patient billed over $50. And for most of our patients with insurance, they're actually covering it. I don't know how much money they're paying the company, but the patient's not getting billed. All right, thanks.
Hey everybody, I have one virtual patient case to present today. All right, so I'm currently on the university inpatient rotation, and this is someone on our service. It's an 18-year-old female diagnosed with juvenile dermatomyositis in 2014. Initially, she had developed some weakness, fatigue, and subsequently some visual loss that ultimately resulted in her diagnosis. She's been followed closely by Dr. Hirsch, a pediatric rheumatologist at Primary Children's Hospital, and they have employed several therapies. The reason we were consulted is because she presented on the 21st with terrible right hip pain, inability to ambulate, and this spreading sclerotic lesion on her right hip. She was initially referred to plastic surgery for a plan for surgical excision, but they wanted to see if we agreed with that plan or if we had any other additional thoughts. So you can see here some of the medications that she's been taking. Notably, right now, she's on prednisone 10 milligrams per day. Prior to being admitted, she was also taking colchicine daily, anakinra every other day, Orencia or abatacept infusions monthly, also monthly IVIG infusions, and bi-monthly solumedrol infusions. She had previously been on Cellcept, 1,000 milligrams twice daily, but this was discontinued in October due to some GI upset. She also said that she was reportedly part of an NIH trial involving regular IV sodium thiosulfate infusions, however, was unable to complete this due to travel difficulties. Here's some photos that aren't very impressive. However, on physical exam, she's got firm subcutaneous plaques that extend over her bilateral antecubital fossa. She is still able to bend her extremities, but you can see the image on the left that she's got a little bit of skin puckering there, and that's all firm subcutaneous cords. This is the area that's causing her so much pain. She apparently had fallen at a pool about a month and a half ago while on vacation with her parents, and the pain had sort of started increasing rapidly at that time with progressive firmness and induration. So on physical exam, she does have some overlying erythema on this particular plaque, just a little bit of scale, but she's got induration that extends centrifugally around this, and then she's got these very firm palpable cords that you can see. Notably doesn't have any sort of extruding chalk-like material coming out of these plaques, but incredibly painful even to gentle palpation. This is a similar lesion she has on the other side, although you can see it has a little bit more of a scaly appearance than the area on her other hip. We did obtain a biopsy of this plaque just to evaluate for changes consistent with morphia versus calcinosis, and didn't identify any calcium in the epidermis or the dermis, so suggesting that the process is much deeper. So my question that I pose to the audience is there anything that you would recommend trying for this patient apart from what she's already received? Do you think surgical excision would be a good idea?
A clarification. So you haven't biopsied that thing, the painful new one, just the old one?
Well, they have been present for the same amount of time. This one's expanding more.
Okay. But but we didn't get fat, or you did get fat?
Did not get fat.
Okay. So we don't know what this is, or what are you calling it? I mean, I guess I'm trying to get
calcinosis cutis.
Where's the calcium?
Yeah, calcinosis cutis. That's why calcinosis universalis. Just
supported by radiographs. So we know she has calcium along fascial planes and in her subcutis, but I wanted to know what this looked like and whether or not there's any augmented skin therapies that may benefit her as well. I mean, clearly this should not be excised, and anything they excise, which she really would like, she wants to get cut on. So anything that gets excised is going to also become calcified. So I really was wondering, I wanted to see if the skin would benefit from UVA1 potentially, even topicals, and then thoughts about other treatments for calcinosis universalis. So she hasn't been on pigmented. We could continue IV sodium thiosulfate, but really I wanted to get your thoughts, Sontheimer's thoughts, Mara's thoughts. Give us advice.
So, because it's so painful. Yeah, I mean, I understand that, but I would have a hard time extrapolating from the findings on one side to this side to know that it would help. I mean, did you see any inflammatory infiltrate on the other side?
I mean, she had thickened dermis. Actually, Scott, you read it, right? Hang on, wait for the mic, please. Emails after this, if not.
Thanks. Sorry. Yeah, I was in the back. So anyway, the punch biopsy showed really good features for connective tissue disease. It had, epidermal changes with vacuolar interface change, and then a lot of mucin in the dermis. Pretty sparse inflammation. And then the biopsy only went to the level of like the deep reticular dermis. I think that was because you said you kind of hit the underlying calcium at that point. So really what we're able to say is it looked, features compatible with dermatomyositis.
So this hurts. Where she has calcinosis all over, it doesn't hurt. So there's something going on here that's unusual. And so a deep biopsy did not tell you what it is. So it's an inflammatory infiltrate. Oh, I thought they did. Well, anyhow, so I would, I would use the equivalent of Cordran tape on this. And leave it on 24/7, changing it every day. A lot of people can't afford that. And there's a cheap form of that. If you just take clobetasol solution, put it on, let it evaporate, and then buy Blenderm tape. You can buy it online, for 6 rolls for $6, something like that. And you can put it over it, and you basically have the equivalent of Cordran tape, or it was a more potent corticosteroid. You could add another anti-inflammatory to that. Just get a pharmacy to compound some protopic in isopropyl alcohol, which is quite stable and pretty easy to use. So there's a reason why this hurts and the other doesn't. And so I would wager that it's the inflammatory infiltrate. And so it'd be all, so inject it with some Chemalog or put on some tape with fluorandrenolide if you want to spend $700 for one piece of tape.
So I think that the thing that would be, but it doesn't sound like the dermal findings or any imaging findings would suggest that. Other therapies that there have been a few reports that have shown that the Janus kinase inhibitors may help with calcium deposition in the patients who get lesionally. She's got a lot of these areas. I don't know of any reports of that in dermatomyositis. It's certainly something done in calciphylaxis. Really painful when you inject it, but it's something maybe, I haven't looked it up recently, so maybe there are reports, but there are none that I'm aware of.
I think there's also a recent single case of a premolast as well. So I don't know if anyone has any pathophysiological explanation for that, but anyway, so from your perspective, additional treatments, adding pigmented, and then anything topically or intralesionally? There, I don't think she would let it.
Widespread active disease that's
not
well controlled, and that's endemic disease needs to be better managed.
Jenny, have you seen this kind of painful plaques with the calcinosis cutis of DM?
Sorry, our mic is twitchy. I have not seen something that looks like this, so I agree. I mean, that's why I understand kind of making sure there's not something else going on. It sounds like imaging shows calcium under this plaque that you have at least deep dermis too, but yeah, I think it's unusual and in its appearance. Pain, clearly yes, with that kind of calcinosis cutis, but it's awfully indurated, and Roma was saying that she's thinking some of what we're seeing may just be that those ridges may be stria, and that it's looking a little bit different because of the stria there, and maybe some atrophy actually.
Yeah, I think a lot of that, the induration is popping up through striae. But she does, on this side, correct me if I'm wrong, Caitlin, on her imaging, she has primarily calcinosis along the fascial planes, very deep, and then scattered calcinosis elsewhere. Yeah, she also on her other leg has a history of hip fracture. So the side we biopsied, she also had a history of trauma. I mean, I think we can biopsy this side. I think it'll be. Yeah, we could potentially have that done. Do you think that would be worthwhile?
So I guess the apremilast idea was, that covers lots of inflammatory inhibitors and could knock down a number of inflammatory pathways, phosphodiesterase, et cetera. But the question is no one not tried that? Where was that idea? Who born that? There you go, Roman.
In JAD.
And it was effective?
It was effective.
So use it.
Thank you.